we might use depending on what the symptoms are. Why anticholinergics? What is that? What is that? What are anticholinergics overall? What are their side effects? What do they do?
Can pee, can shit, can.
There it is. Can't pee. These are the side effects. So why would we use an anticholinergic? It can make us constipated. So what would we use it for? The patient that has diarrhea. It would just slow things down, right? It's kind of like using it for one of the things that it does for us. It actually can give us constipation. We would use it for the irritable bowel person that has frequent stools. So again, many times it's figuring out a med that's going to work for this patient and then going keeping that med. Figuring out what the triggers are, treating the patient, treating the triggers, treating the symptoms. Okay. So here's some of the meds that we could use as common, most common digestive disorder. There's a little bit about it in your book. Read through it, understand what irritable bowel is. It's different than Crohn's, it's different than ulcerative colitis, it is its own diagnosis. Again, like Sam was just saying, a lot of abdominal symptoms all seem like the same. Abdominal pain, bloating, tenderness, distension. So it's really hard to tell what the patient has until we do some diagnostic tests, until we get labs, until we figure out you have irritable bowel because you have nothing else that we can find, right? You don't have diverticulitis, you don't have Crohn's, you don't have this, you don't have that. But what we do know is your triggers are this. Well, after I eat dairy or after I eat cheese, it seems like I have more symptoms. Okay, so what other symptoms do you have? And the patient goes on to tell you what other symptoms they have. So here's some different meds that we might use. The patient's constipated. When we use stool softeners, yeah, depending on their symptoms. If they have diarrhea, anti-diarrheal medications. If they need histamine receptors because they have a lot of GI distress, we can give them some of those H2 meds that we talked about yesterday. We might use PPI meds for this patient to treat the symptoms that they have. And here's some tests we might do in order to try to diagnose it if we can. Okay, moving on to there's a couple meds. There's another one called Lodonex. It's a med that we, again, specific for women who have irritable bowel with lots of diarrhea. And you might use this med for that patient to try to treat the symptoms. Irritable bowel steroids might work because it is kind of inflammation that's happening. Not always, because chronic steroid use is not the best thing. Okay, so here's ulcerative colitis. What is this? This is inflammation, mostly of the large intestine. It usually affects the colon, that's the large intestine. How is this different than Crohn's? If somebody has ulcerative colitis, they have bloody stool, 15, 20 a day. That's a lot. They get dehydrated very quickly. It affects the lower intestine, the large intestine, it affects the colon. Look at what their symptoms are. Pus and blood in their stool, 15 to 20 loose stools a day. So if somebody has ulcerative colitis, we can identify that pretty quickly. Because if you came into the hospital and said, I have went 20 times a day and it's bloody, you're going to get dehydrated pretty darn quick. We're going to have to figure out what's going on with this colon that's creating this inflammation that's happening. And it's a diagnosis, it's a disorder. Other symptoms, abdominal pain, tenderness, cramping. The patient might be incontinent on stool because look how many stools they have per day. And it's so loose that sometimes they can't even control it. Here's basically what it is: widespread inflammation of the rectal and lower sigmoid colon. That's all the colon that's at the bottom, right? That's where our sigmoid colon is. It can extend to their entire colon, so we need to recognize that colon means the same thing as large intestine. Here's our risk factors: family history of having this. Jewish ancestry puts you at high risk. I don't know why. I don't even know what the link is, but it's there. Being Caucasian, young to middle age, or 55 to 65. I don't even have any idea why it's just those ages, but this is when we most commonly see symptoms and signs of ulcerative colitis. Peak age is adolescence. So imagine the female adolescent that's 14 years old that has 15 loose stools and it's bloody and they're dehydrated and no one can figure out why. This is the picture of the ulcerative colitis person. Usually white. There tends to be a Jewish link to it, family history, and then typically younger 15, 20-year-old is typical presentation of ulcerative colitis. And they get dehydrated, fluid buying deficit very quickly. Liquid bloody stools, they typically have a low-grade fever. What do you think about their white blood cell counts? That can be up or down? Up, because it's inflammation. What about their H&H? Why? Because they're bleeding. 15 to 20 loose bloody stools every day. Don't you think your H&H is going to go down? It goes down pretty quickly. How do we treat these patients? We might have to give them blood if there's enough blood in the stool that their hemoglobin is down to 6 and they're tired and weak and they're passing out. We might have to give them blood. We give them IV fluids. We try to minimize what it is that's a trigger in their diet. It might be NPO. We might have to put this patient on TPN for a few days in order to get them nutrition. So here's the cause. This is what it is. Basically, abscess is formed within the colon or lower or large intestine. And here's some diagnostic tests that we might do. We don't even have to do stool or called blood if you're pooping out right red blood. We don't have to do that. We know that's blood. But they might get lower GI barrier. We think we want to do a colonoscopy right where they were all inflamed and irritated. Why not? What's our risk? If we stick a tube up into your bottom and it's our perforation, right? Bleeding. So don't pick colonoscopy for this person, because if you're pooping 15 to 20 bloody stools, no one is going to want to put a colonoscopy tube in your rectum. No doctor should be doing that because they're very likely to get a perforated bowel. Should we do any kind of enema or rectal tube for this patient? No, they don't need an enema first off, but a rectal tube has complications too. So we're not going to put any tubes in their bottom. Certainly we're going to go to the bathroom, but we're going to have to think about dehydration, fluid status, what kind of nutrition are they getting? The meds can give them. These people with ulcerative colitis, when they come into the hospital and it's acute flare-up of this, we give them steroids. So they might get IV Cyanidrol or methylprednisolone or whatever the steroid is because it's inflammation. Imodium, and we just talked about that, to slow down their bowels, to slow down that motility that's happening there. Dietary recommendations. What do we tell them? No milk products, no spicy foods. If you are going to eat, make it high protein, right? Things that if you can only eat a little bit or tolerate a little bit and everything's moving through you quickly, things that you're going to get better nutrition. And there's that TPN, total parenteral nutrition. There's that IV nutrition that we talked about. Minimize your stress. Many times that's a trigger for these flare-ups. Help the patient cope with other things in their life that might be that flare-up. Ulcerative colitis, in a nutshell, what is it? It's abscesses in the lower large intestine, the lower colon, usually the sigmoid area is affected, the rectum is affected. Loose bloody stools, 15 to 20 a day. Patient gets dehydrated quickly. Stress is many times a trigger. It's usually females. It's again usually Jewish ancestry. 15 to 25 is the age group. These are things that you should be writing down. That ulcerative colitis, low H&H, high white blood cell. What about their SED rate? Where do you think that's going to be, up or down?
More than 20.
SED rate is inflammation. ESR, that's what you might see on NCLEX. It's going to be up. C-reactive protein, that's going to be up. It's a lab that we get. No colonoscopy for them. No rectal tube. Treat the symptoms. Try to slow down the virus. Give the patient blood if they need it. Give the patient IV fluids. We got to think about nutrition for them, because when they eat, if everything's moving straight through, what are they not doing? They're not absorbing anything. It's just going right through them. 20 times going to the bathroom bloody a day. Imagine how you're going to feel after 1 or 2 days. Pretty darn crappy. So they get sick pretty quick. So here's some diagnostic tests that we might do. We got to think about dietary. Don't eat milk products. Don't drink milk products. Again, no spicy foods. High protein will be good for these patients. And they need steroids. If the colon does not heal and it's severe enough, sometimes these people need surgery to remove that part of the large intestine that's so inflamed and infected and irritated and everything we're doing medically wise is not working, the patient might be surgery to remove that section, and like we were talking about, they might end up with colostomy. It might be able to be reversed, it might not. So ulcerative colitis can get pretty bad for people. And again, we're looking for signs of hemorrhage, we're looking for signs of perforation of that colon, and we're making sure that these are the complications that could happen in the patients, obviously getting surgery. There's those labs again. We would be getting HA, get a white blood cell count, a sed rate, a C-reactive protein, all the things that we've just talked about. Recognize what's going to be high and what's going to be low for this patient that has ulcerative colitis. And they might end up with a colectomy where we have to take out part of that colon and create a bag. They might end up with an ileostomy. Now, if they have an ileostomy that's higher in the small intestine, what's that stool going to look like? More liquid or more formed? More liquid. So you just have to think about where's the collapse, where's the location of the part of the bowel that they had to take out. And that's going to tell you what the student should expect. Here's our nursing care. The patient has ulcerative colitis. How are you going to feel if you had 20 stools a day? Tired, weak, promote rest for them, IV fluids, steroids. That should say maintain NPO status when they first come in. Why? Why wouldn't we keep them NPO? You know, we just said we want them to have good nutrition, high protein, but when they first come in the hospital and they have had 20 stools in the last 24 hours, what are we going to do if we start to keep feeding them? We're just going to keep peristalsis going, right? So wouldn't it make sense right when they first come in and they're really, really sick and everything's just moving through them? Don't feed them right now. Let their bowel rest, slow everything down, just give them IV fluids. So in the acute phase, all that really means is when they're very sick and they're first getting treatment, keep them NPO. And then we can progress from there and let them have some clear liquids maybe in a couple days if their bowel's starting to recover or symptoms start to go away. How do we prevent fluid deficit? IV fluids, right? We might have to do TPN. When they get back on the diet, remember, we're trying to avoid dairy, low fiber is what we want, and we want high calories. So again, in the acute phase, if it says the patient was admitted with 20 loose bloody stools today, this is your story on NCLEX. What's your diet going to be NPO for right now? Until we can slow this down. Can we do Imodium or anti-diarrhea? Yes, we can. Could we possibly give them blood? Yes. Let's see what the hemoglobin is. That's how we treat it when you first come in. And this is just showing some pictures of, again, calcium and it's just a surgical intervention. We have to remove part of that large intestine. All right, Crohn's disease. How is that different? Crohn's disease affects the small intestine. Ulcerative colitis usually affects the large intestine. So Crohn's disease, what is it? It's inflammation, scarring, thickening of the bowel wall, and look where it usually is, the distal ileum. What is that? That's part of the small intestine. Remember, we said there's 3 parts to the small intestine. So Crohn's disease is more like a generalized inflammation of the small intestine. Ulcerative colitis is specific area of the large intestine. So you just got to compare the 2 different things. Look what happens when somebody has Crohn's disease. Look how many stools they have, 3, 4, 5 a day. It's not as bad as ulcerative colitis. It's not as acute. The patient doesn't get as sick as quick with Crohn's disease. Anybody heard of Crohn's disease before? You've seen questions about it, or you heard about it, or heard it on TV, or heard a patient that had it. So what happens? It's inflammation and basic thickening, I guess you could call it, of the bowel wall. And it's usually the small intestine that's involved. Think about how long our small intestine is, 23 feet. So that means it's kind of spread throughout the entire stomach. So what do you think their pain is going to be like? Pain throughout their entire stomach. What do you think the pain with ulcerative colitis is going to be like? Where's it going to be located? Lower, because that's where our colon is, right? So it should start making sense to you. So now this patient with Crohn's is diffuse abdominal pain, but again, all of these symptoms are so much alike, it's really hard to tell. This patient starts losing their appetite, they feel weak, they feel tired, doesn't change, we're still going to give them rest periods, but look how their stool is much, much less. They might have steatorrhea. What does that mean?
Fat in the stool.
Fat fat in the stool. So normal stool doesn't have a lot of fat products in it. Steatorrhea also means this person, when they have those loose stools, maybe that white kind of pasty color. It's lighter in color and more fat in the stool. And again, you never thought you'd be happy to sit and listen and hear about what stool sounds like or what it should sound like, but you're a nurse now. This is the stuff that you're going to see. So again, they might have problems with not getting enough nutrition. They might become dehydrated, but they're not going to become dehydrated as quickly as ulcerative colitis. So you just need to compare the two. And there's a chart coming up here at the end that kind of helps us do that. All right, this is inflammation, so what are we going to pick? Steroids. It doesn't change. All right, steroids are still okay. If it's, can we get Crohn's disease flare up from a bacterial infection? Yes. So if it says they have a bacterial infection, give them antibiotics. If they have diarrhea, give them anti-diarrheal medication. Figure out what it is. But look, now they're going to give them vitamin B12 again too, because now they're not absorbing that and it's not testing. So here's Crohn's disease. Here's the patient. They're sitting on the toilet. They have severe diarrhea, 4, 5, 6 stools a day. They might have a little bit of a fever. They can have some blood on their stools. It's not as bloody as ulcerative colitis. They may have nausea and vomiting. They may have tenderness. And then the basic signs and symptoms of basically this here. And our complications could be peritonitis or dehydration or fluid volume deficit, whatever it could be. So this is your picture of your Crohn's disease patient. Their peak age is around 15 to 40. So kind of similar to ulcerative colitis, it just depends on the location of the valve it's involved. So here we are, back to high protein again. Avoid lactose-containing foods, that didn't change. Avoid caffeine. Avoid alcohol, no beer, no carbonated beverages, because that's only going to make more gas and problems with them eating. And again, Crohn's disease could need surgery if that part of the valve does not recover with medical treatment that we might do. So this is kind of comparing the two things, Crohn's and ulcerative colitis. There's a chart here at the end. We're almost there. Here it is. Comparing the last 3 things that we're talking about, ulcerative, Crohn's, and diverticulitis. So you at least have this chart to kind of go, kind of give you a general idea where your labs might be, what we would expect with ulcerative colitis. The hemoglobin and hematocrit's going to be decreased with all of them. What's going to be increased and what's going to be. So just compare them, right? This might be something that's in your story on NCLEX and you recognize what's happening with this patient. Quickly, in a nutshell, what's diverticulitis? Anybody know? Inflammation. So diverticuli, look, somebody can have diverticulosis. Write this down. You can have diverticulosis without having diverticulitis. Okay, what the heck does that mean? Diverticuli are little pouches that are on the intestine itself. They're little kind of like herniations or little pouches. Okay, so this is the large intestine. See those little diverticuli? They're like little pouches that are on the intestine. Normally, in time, as we age, one of the risk factors, we can develop these. Look what can get caught in these pouches. Stool. We tell the person with diverticuli, they had a colonoscopy and the doctor noticed, okay, you have diverticuli that we notice on your valve. What are some of the things that we tell them not to eat? Anybody ever read this or heard this? Seeds, nuts, popcorn, corn. Why? Look at what it is. Strawberries, they have little nuts on them. See these little diverticuli pouches? What do you think could get caught in those little diverticuli? All those little things that normally move through our mouth. Now with a person with diverticulosis, that's the what's present. When they get caught and this gets inflamed, that's when it's called diverticulitis, because now that diverticuli are inflamed. Everybody understand what I mean? So you can have these and not have any problems. How? Would we tell that person to drink a lot of extra fluid? Why? Help it all move through. Wouldn't it make sense? Wouldn't we tell that person to take stool softeners? Yes, because we want to make sure they keep going to the bathroom and things don't get trapped and caught in there. When those little diverticulum, that's what they're called, get inflamed, that's when it's called diverticulitis. So patients will come in and out of the hospital with flare-ups from diverticulosis disease, and a GI doctor will diagnose them with diverticulitis. Okay, what happened? Well, who knows? Maybe they weren't drinking enough fluid. Maybe they ate something with dry that they shouldn't have. Maybe they're constipated and stool is now caught in there. So what happens? You give them a lot of extra fluids and try to push that through. So this is just basically comparing the difference between diverticulosis, that just means the presence of these pouches, and diverticulitis. Everybody okay with that? So if there was a true or false, which there will be on the pretest, somebody can have diverticulosis and not have diverticulitis. That's true. That's true. If it becomes inflamed and infected, now what's going to happen? The white blood cell count's going to go up. They're going to have a fever. They're going to have a you might have to do surgery. So I just want you to recognize what diverticulitis even is. It's another inflammatory bowel disorder. Where is it located? Usually large intestines. It's most of the time where it affects. What kind of diet do you put them on? Low residue. We use stool softeners. We give them extra fluid. If they develop that diverticulitis and the white blood cell counts up, we might give them steroids. If they have an infection going on, we might give them antibiotics. We might have to do surgery. And then here's our risk factors for developing this disorder. Here we are again. Jewish people, Caucasian, constipation frequently, people who eat low fiber, high fat, red meat are at risk for diverticular disease. These are the things that we tell them to avoid. Popcorn, nuts, any foods with seeds. Drink more fluid. Manage your pain. Take your laxatives. Don't get constipated. Monitor yourself for any kind of symptoms of obstruction or any kind of increasing abdominal pain. Pay attention to how often you're moving your bowels. Stay on a high fiber diet. Here's some meds that we might have to use, or we might have to do surgery. So this last column, compares these three things. And I think we probably reached our limit at this point. Now, that was long, but this is, I think, PowerPoint 3, 4. What is this one? 4. On Monday, when we're back in here, we will go over hepatic issues, gallbladder, pancreas. It's on a different PowerPoint. That stuff is on the back. All right, so what's our plan? This afternoon, we're going to do IMD stuff with you guys that are in here. I think it's Miss Denise and who else is here with her? Who else is here? You have your GI packet to work on. I'm going to send you GI questions that you're going to be working on. I'm going to send you 40, I promise. It won't be as many. Tomorrow, everybody got the email on what we're doing tomorrow. You guys that are at home, group 1 and group 2, I need a couple people tomorrow to go to Seasons Hospice. Anybody from here want to go? You guys, this is 4, 5, and 6. So you guys are all out of clinical, so there's no reason to send you guys there. Anybody from group 3, look for an email. I will send you the names of who's going to Seasons Hospice. Is group 3 here in the on Zoom?
Yes.
Yeah.
Okay, I will also send you who's going to Brandywine Counseling. So look for an email so you know who's going where for the next couple days. 2 people can go to Seasons Hospice, 1 person can go to Brandywine Counseling. The other people should be in here based off of the email that I sent earlier in the week. 1 and 2 will be in here tomorrow with Cassandra.